I'm Grant Garcia, sports shoulder surgeon here at Orthopedic Specialists of Seattle. Today we're going to talk about shoulder dislocations and shoulder labral tears. Again, like our previous blogs, we're going to start with anatomy to better understand this issue. So here, you have the shoulder joint, you have the ball portion called the humerus, and then you have the socket portion called the glenoid. Around that socket, as you can see here, this is a more zoomed in view, you have the labrum, which is the bumper. On the top is the biceps tendon, and in previous blogs we've talked about slap tears, which we will not talk about today. Now if you tear the labrum in the front or the back, this is when you can have shoulder dislocations, and we'll talk more about this. So again, first time shoulder dislocation, usually we want to promptly get the shoulder back into place, and that's only the first part. Once someone's had a shoulder dislocation, we want to start thinking about other issues that can occur. But the first thing we do is make sure we have x-rays to make sure there's no injury or other fractures present. If there isn't, then we usually try physical therapy and try to get patients back to sports without any surgery. In general, we try sling for a short period of time, and then we try to get prompt physical therapy. Most patients can get back to sports between 4 to 6 weeks. Again, age does matter, so under 40 years old we worry about fracture or nerve injury, and again that's why you want to see an orthopedic surgeon, sort of have this evaluated and make sure these are not present. If someone's over 40, and I see this more commonly, we are worried about a rotator cuff tear. If I think this is present, I'll get an MRI to make sure that there is not a torn rotator cuff. If there is, we do consider surgery in some cases, but for the most part, in any type of first-time dislocation, we try not to do surgery. It's important to understand that patients under 20 need specific counseling even if it's their first dislocation, because the data shows that patients under 20 have a 90% chance of redislocation without any surgical intervention, and that's pretty concerning and something that people need to be aware of. Now, when patients start having more dislocations, and generally the younger patients are, the more aggressive we want to be about fixing their labrum because we want to prevent arthritis in the future. So let's say someone's had more than 1 to 2 or 3 dislocations, then we consider surgery, and these are generally for younger patients. The surgery is quite successful. We've seen success rates around 90% return to sports, with around 10 to 15% recurrence rate at 10 years. Again, what we do is we arthroscopically go into the shoulder, replace 3 or 4 anchors on the bone of the socket, and repair the labrum as well as the capsule back. And this is all well and good, but it becomes more complicated, and this is where you really want to see a specialist for this. Again, when patients have had a previous labral surgery, or they've had more than 10 to even hundreds of dislocations, we need to start looking for other things. So I showed you previously there's the ball portion or the humerus. Well, when patients dislocate their shoulders, they can actually hit the front of the shoulder and cause a big dent in the back called a Hill-Sachs lesion. Essentially what it is a pothole that can allow the shoulder to be sort of catapulted out each time. And if you just do a basic labral repair for someone with this bad of an injury, you can cause a much higher chance of it redislocating again. So what I like to do is add another procedure called an arthroscopic remplissage. So as you can tell, it's arthroscopic, so it's still through those same small poke holes we use. But what we do is we take anchors and we put the rotator cuff tendon in the back of the shoulder into this pothole, and also repair the labrum in the front. But what's good about that for both failed previous labral repairs and for people with this large Hill-Sachs lesion is that we've dropped the recurrence rate from 10 to 15% at 10 years to under 5%, which makes it a very successful surgery. The second thing you want to worry about is moving away from the humerus or the ball portion and focusing more on the socket. I see this more commonly, but if someone dislocates all those times I mentioned before, or has had a previous labral surgery with anchors arthroscopically, they can wear the socket down in the front. And imagine a golf tee missing the front half of its sort of tee or the bony portion. Well, when you wear down around 15 to 25% of the socket, a regular small, simple soft tissue anchor repair is not sufficient, and we need to do something called the Latarjet. And so what the Latarjet is we take a piece of the coracoid bone in the front and we reattach it there in the front. Again, this is a very successful surgery in these types of patients, but it's something patients need to understand is that one of the highest complication rates that we have in sort of shoulder instability surgery at around 13%. And so this is why you need to make sure you see somebody who's experienced with open shoulder and has not done only 1 or 2 of these a year. Now, moving on to even more complex scenarios, let's say someone's had a Latarjet or someone's had multiple failed surgeries and the Latarjet is not an option. We have another option called the distal tibial allograft. That's the fancy word, but really what it is I take the cadaver bone of an ankle and we put it on the front of the shoulder. It has cartilage in the front too, so it can actually preserve patient's sort of socket for a longer term solution. Again, this has very good results in the right scenarios, but again, needs to be done by someone that has experience in this area. So as you can see, labral surgeries, shoulder dislocations is a complex algorithm. It's not a cookie cutter method that just means you need to arthroscopically have it fixed. And this is why it's important you go to someone with experience not only in understanding and evaluating these types of injuries, but with these types of surgeries from the arthroscopic standpoint as well as from the open standpoint. So if you or a person you know or your family member has a condition such as this, please contact my office at Orthopedic Specialist of Seattle by searching it, or on my website at www.grantgarciamd.com. Thanks.